Hi everyone, and welcome to today's Scottish Drugs Forum webinar. I'm Dave Little, CEO of SDF, and I'll be chairing today's session, which will run no later than 2:20. This is the fourth in a series of webinars focusing on the medication-assisted treatment standards from 1 to 10. The aim of the webinars is threefold. Firstly, to continue to raise awareness of the standards. Secondly, to highlight emerging good practice. And thirdly, to highlight challenges that remain with full implementation and how these challenges might be overcome. Today, we will be focusing on MAT Standard 4. A link to the full standards is provided in the chat. We will start with a short input from someone with living experience, which has been presented at a previous SDF webinar, and this will be followed by presentations from John Campbell, Harm Reduction Lead, NHS Greater and Glasgow and Clyde, Simon Pringle, Service Manager, Alcohol and Drug Action, Aberdeen, Laura Rothney, Senior Nurse Practitioner, Aberdeen Integrated Drug and Alcohol Services, Joe Tay, Clinical Services Director, Leads Forward, and finally Donna Thane, Managed Care Network Manager, Sexual Health and BBV Directorate of Public Health, NHS Tayside. So if we can just now begin with the living experience contribution.
I think it's a great idea. Basically, it sounds like it would save lives to me, because if you're accessing services and you're wanting to change your life, that doesn't mean that everybody around you wants to change your life as well. So you could still be associating with people who are in active addiction or whatever, and you might be in a situation one day where naloxone is needed. You know what I mean? Where you're in that emergency situation, somebody's dying in front of you, you know what I mean, ODing, and because you've got that naloxone or because you've got access to it, they might survive that day. So that's a life saved. The other one is, you have bumps in the road. I had bumps in the road. I went back to it a few times, and having clean equipment is probably one of the reasons why I'm still alive today. You know what I mean? And why I haven't got some of the bloodborne viruses that come with using dirty equipment. You know what I mean? So it saves lives, and it sounds like complete common sense to me.
That's a helpful introduction, I think, to the topic we're discussing today. If I can begin by asking John Campbell to present. Over to you, John. Thanks.
Thank you, Dave, and thanks for the opportunity to present at today's webinar. It's a relatively short presentation, but throughout this I'd like to talk about the rationale for introducing WAND within Glasgow city centre, and I guess talk about some of the problems we had during implementation and how it could possibly be implemented within alcohol and drug recovery services. Okay. I think to properly understand the need or the rationale for introducing WAND, we have to look at what was happening with harm reduction in Glasgow City, certainly, Greater Glasgow and Clyde, 2 or 3 decades. Our harm reduction response tended to be one that was dealing with an emergency situation. So it was responsive, but very seldom properly planned, which meant there was no real consistency in the approach or the interventions that we provided to clients. When you look at our specialist services, so our drug services, if you like, certainly clients view them more as treatment centres than any centre that would provide them with low threshold access to a range of harm reduction interventions. But there's certainly been a number of harm reduction successes in Glasgow throughout the years. The expansion of the IEP programme, we now have 77 different outlets across the board area. Whenever there's new paraphernalia available, and we're allowed to provide that through the Misuse of the Drugs Act, we do. Along with Lanarkshire, we started the first naloxone pilots back in 2007. And I would love to say that as we've improved those harm reduction interventions and increased our IEP programme, then harms have fallen in line with that. But the reality is they've not. The key harms we are dealing with today are the key harms we've had to deal with for the past 30 years. We're still faced with pretty horrendous injecting-related complications, which appear to be worse now with the frequency of injecting of cocaine. We know the fatal overdose rate has been continuing to rise year in year in Greater Glasgow and Clyde, bearing the largest brunt of those deaths. And I'm sure most people here are aware that, again, in Glasgow, we're currently living through an outbreak of HIV. We now have 190 individuals that contracted HIV and linked to the outbreak that started in 2015. So the WAND initiative was designed to promote interventions that are designed to tackle those three key harms. Wound care. Now, with wound care, all we really want is to encourage the client, encourage the individual to sit down with a trained member of staff and allow them to physically check and assess the health of their injecting sites. The key component to the whole WAND initiative is the assessment of injecting risk. It's a very comprehensive assessment that guides the member of staff and the individual through the assessment process. I think sometimes I'm guilty of maybe discussing this or promoting the data that comes from this as some type of survey, a bit of research, and it's not. It's a proper assessment. At the end of that assessment, we want the member of staff to make a plan for the individual to try and help them reduce injecting-related harm that has been identified as part of that assessment. When the naloxone provision, we don't want to just keep churning out naloxone kits. We want clients to come in for that round of WAND, come in for that assessment, actually carrying a naloxone kit. So you can see what we're trying to do there, almost train people into carrying naloxone. And dry blood spot testing, as you can imagine, with the backdrop of HIV and potential reinfections with hepatitis C, we want people to be tested, but we don't want people to be tested just as a one-off. We want them to come back every 3 or 4 months for testing, as the guidelines suggest. And that's really why the 3-month frequency of WAND is in place. And of course, we use the WAND initiative with a very desirable incentive, which is access to £20 cash. Thank you. Very lucky to have Public Health Scotland, so Shanley Smith, Kirsten Trainer, Andy McCauley and Sharon Hutchison do a full analysis of the first year of WAND data. So this is data from our assessment of injecting risk. So 831 unique individuals participated in all 4 interventions. When we look at the breakdown male to female, see 78% male. That's pretty much what we would expect from our IEP services. The age range, the largest group between 30 and 49, fits the profile of a drug-related death age range as well. We start to look at the drugs that's injected, it gets a little bit more interesting. So in that first year, 77% of clients injecting heroin, 65% reported injecting cocaine. The reality is, for most of those individuals, it was both those drugs that was being injected. I'm not presenting on it just now, but if I look at the last year's data, there are actually more people in Glasgow City injecting cocaine now than there are heroin. And for those individuals in the first year, 56% of them injected daily. So it shows quite a high level of injecting frequency. And nearly half, 44% of them injected away from the home environment. And 37% reported frequently sharing paraphernalia. Okay. Now, we wanted to make sure that we were engaging with the right population. So where we could, we linked this data with the Needle Exchange Surveillance Initiative. And there's a few surprises here, but we thought it would come out, very, very level. So through the NESE study, 23% had reported having an overdose in the previous year. For our group, accessing WAND, that was 34%. 20% of the NESE group had reported a skin, a soft tissue infection. Theirs was 53%. Then you look at the awareness of their HIV status, NESE group, 79%, but in ours that was only 35%. And, very, very similar for picture for hepatitis C. This is really concerning in a city that has an outbreak of HIV. And we've essentially been screaming for the rooftops about the need to be tested and be tested frequently. So I think it shows that we were engaging with the right target population. Thank you. Okay, again. Okay, so the baseline obviously is people when they first engaged with the Wand Initiative, and we then looked at those people who had come back within the next 12 months for a re-engagement. So benzodiazepines had fallen slightly. The number of individuals injecting heroin had fallen fairly significantly. And of course, as I mentioned previously, you know, that coincides with that increase in cocaine injection. So the 53% had been tested for HIV had increased to 80% after the Wand Initiative. Well, why? Because we're testing for hepatitis C for 56% up to 84%. And for me, one of the most outstanding figures was that those individuals coming in carrying naloxone, 21% of the individuals that came back for the next round, that had increased to 32%, which I think goes to show that at least some of the key messages that we were promoting was taken on board by our clients. Okay. There were 4 key stages to introducing Wand in Glasgow City. And the first one was probably the most difficult, and that was to get some sort of acknowledgement that the key harm reduction interventions that we should have been offering were not offered. You know, initially it was reported that, yeah, they were offered, and there was absolutely no evidence to back that up. It was if it was offered in any sort of consistent manner, certainly. Which meant there was certainly gaps in knowledge, certainly gaps within the staff team. So to provide those teams with intensive training, then we moved on to the implementation stage. And of course, it needs continual monitoring, support and quality control. Okay. I really struggled with this, if I'm honest. You know, I know the basis of my presentation had been, you know, how we could introduce Wand within our drug treatment services. This is just 4 very basic harm reduction interventions. And I think if our specialist services, you know, we've come through a decade of such a high prevalence of hepatitis C, an outbreak of HIV, we've had outbreaks and deaths with Clostridium novi, with botulism, with anthrax. You know, we know we've seen horrendous injection-related complications. And if we're not providing those most basic interventions, then I think we need to ask ourselves why we haven't been doing that. And the reality is, for me, the Wand Initiative was introduced in Glasgow not through our specialist services. It was introduced using the third sector, you know, and particularly the Simon Community Hub in the city centre, the Glasgow Alcohol and Drug Crisis Service through Turning Point Scotland, and Waverley Care. And the reality is, if I never had their support, or we never had their support, then the Wand Initiative would not have been implemented. Okay. If we had to look at this in a national level, then I think it's going to need some sort of leadership and coordination. But I think harm reduction in general really needs, you know, a national lead. I would imagine the first task that person would want to do is do a proper in-depth audit of the current harm reduction provision, evidenced harm reduction provision across the country. Just as we to train the staff at a local level, I think we should consider 2 or 3 training centres of excellence where everyone can tap into and send staff to be trained. And then it would be just the stages of implementing the initiative, monitoring it and providing support to the services that are participating in it. Thank you.
Thanks, John, so much for that. There was quite a few challenges in there. I guess we'll come back to that in the Q&A session, but thanks very much for now. Our next speakers are Simon Pringle and Laura Rothney, who are going to talk about the provision in Aberdeen. Simon's going to go first, then Laura. Over to you, Simon.
Thanks, Dave. Yeah, we're going to look at a kind of integrated approach within Aberdeen. So Alcohol and Drugs Action, Aberdeen City ADP and NHS Grampian have been looking locally at how we can offer better holistic services to clients, and using a variety of entry points and in different approaches to get access to clients. Sometimes we hear the term one-stop shop to describe access to treatment and harm reduction, but I'd like to think of around several venues, and indeed not just relying on clients coming to us. I think that lots of services have learnt to be more flexible, firstly due to necessity through COVID, and then trying to continue what's kind of worked really well. So I'm going to present a very short case study example that will hopefully give some flavour of this, and then Laura will briefly outline some initiatives that we are working on together to further enhance services. So the case study I want to talk about is a male, 54 years old, sorry. He's been using more than 35 years, both alcohol and drugs, and had significant childhood trauma. He was seen by our Sharp Response mobile needle exchange service. This was a service that we initially set up in response to COVID. During discussions around potential referral into treatment from Matt, it became apparent that this gentleman would struggle to attend and keep engaged with services. So we liaised with the senior nurse practitioner, who actually...
I think we appear to have lost Simon. Laura,
I can jump in.
Okay,
Yeah.
thanks if you would. Yeah, that would be helpful. Thanks.
Yeah, so the gentleman Simon was speaking about, so yeah, was identified by him that coming through our traditional routes into clinical treatment just wouldn't work for him at that time. We have just recently started a test of change of having a clinical non-medical prescriber based within ADA's main hub, where they provide their main needle exchange and their duty drop-in. So it was agreed that he could come there. So he was supported there by ADA staff. He seen myself there for assessment of dependence and diagnosis, and we had that discussion about what treatment options he would like to explore. So through that discussion, it was agreed that he would like to commence on methadone. So following that route, he was able to start on a prescription within that 24-hour period, and then his care was moved on to a key worker established in our assessment clinic. He was supported to those appointments initially by Drugs Action staff. During that time, he unfortunately was unable to get to the chemist, came off prescription, but again was picked up by the Sharp Response team to look at how they could support him to maintain that. This gentleman's now been on a prescription for 6 weeks. During that time, he has been linked back in with hepatology to look at PCR testing for hepatitis C. And despite the challenges of him thinking he wouldn't be getting into treatment, we were able to do that in a collaborative way through Sharp Response coming into that clinical treatment. So I was going to move on to speak about what established things we have in place and what initiatives we've got going. So within the clinical service, we are an established integrated service with clinical staff, social care and third sector through alcohol and drugs actions embedded within all our multidisciplinary teams. The positives of working in collaboration together has allowed barriers of access to be reduced. So, there's no internal referrals. It is very much about who is the best professional and what support is needed at that time. It's well recognised that we shouldn't be expecting people to come to us for support, but for us to be taking that support to them in the right place. So whether that's within a local community setting or within their home. The test of change we've mentioned around our direct access prescribing clinic, it means that having somebody established within that service who have already got relationships with people that might not be coming to the clinical service, it just complements what's already established there. Through COVID and our remobilisation, we've been able to reinstate hepatology clinics. Specialist hepatology clinic nurses are within Grampian have got a CEPID machine, which is a portable testing machine that provides rapid PCR testing and the results within an hour. So we're currently using that within various areas of the clinical service. Within third sector, they're also looking at prison and custody settings for testing. Initial assessments for treatment, we have an opt-out approach with dry blood spot testing and naloxone training. So being able to have CEPID testing there, somebody can have their result during that assessment period and if required, discussion and initiation of treatment can happen on the same day. Like said, in terms of naloxone, it's an opt-out approach for individuals at risk or their loved ones. Part of my role as senior nurse practitioner is to bridge the gaps and build relationships with colleagues within the general psychiatry and older adult psychiatry community nursing teams. So within the last year, we've been able to provide education on overdose awareness and provide naloxone team training to that teams to distribute to people they are now involved in. ADA staff and our specialist pharmacists have also provided naloxone training to a number of junior medical staff joining the Aberdeen City Mental Health and Learning Disability Service. One challenge we have had has been the recruitment of nursing staff and ensuring a robust and consistent training package is available on induction, particularly around needle exchange provision and wound care. We're currently in the process of looking at a service plan in terms of training and capturing the key harm reduction interventions to be included for consistency and to ensure that practice is up to date and evidence-based, which will hopefully allow what is being offered by every member of staff, regardless of who your key worker is. It's not a postcode lottery in that case. ADA have supported this with needle exchange training in terms of their expertise. And going forward, our goal in Aberdeen is to provide clinical service within established community hubs across Aberdeen City localities who already host ADA services, community groups and peer support to provide more options and choice for people of how they wish to receive their support. Thank you.
Great, thanks very much for that, Laura. And apologies that we lost Simon there for a period of time, but some important points there I'm sure we'll come back to in the detail. I'd now like to welcome Joe Tay, who was involved originally in the MAT standards and then moved sadly to England, but we're delighted that he's come back to talk to us today. Joe.
Hi, nice to be here, and thank you for asking me. So yeah, just to talk about this particular MAT standard 4, and alongside the delivery of medication-assisted treatment. And I suppose encapsulating it really, it's not about what we want to deliver necessarily, it's what people need us to deliver. And really that is what we're talking about today. I put this in there because I found it online, thought it'd be interesting for people to have a look at where MAT standard 4 is relevant relative to the other ones. So this is from 2020, 2021. It's the government's statistics, I suppose, about the benchmarking statistics about where things are just now. And it's just also a bit of a reminder about what the harm reduction standard actually says. Great. So this slide, I think, really encapsulates again why this is such an important area. If this is about health, and I believe it's about health, I'm sure everyone here does as well, then it's really impossible to think of harm reduction initiatives, or not initiatives, interventions, and the delivery of medication-assisted treatment as not being part of the same picture, really. As you can see there, IV drug use in particular, overdose deaths, injury, bacterial infections, a lot around the skills of how to inject is, certainly in certain parts of the UK, that knowledge is disappearing as people kind of start to get their training, I suppose, really from standardized sources, not necessarily from lived experience, sterile injecting equipment, BBSD and microelimination. All of this fits together alongside the delivery of medication-assisted treatment. I personally don't see how it can be different from each other. I think they need to be offered together. So the WAND initiatives, I hadn't heard of it before. I had to ask Dave Little what this was about, but I have to say I was very, very pleased when I read more about it. I think it's a really good way of bringing things back to reality, I suppose, really just a reminder of all the things that traditionally we have tended to be quite good at, I suppose, in Scotland. But we've had a pandemic in between, lots of in-person contact hasn't happened, and the focus, I suppose, in many ways on medication-assisted treatment, quite rightly so, can't be at the expense of these other equally important interventions. So wound care or wound aware, depending on how you look at it, assessment of injecting risk, naloxone and dry blood spot testing. The following few slides are really just a play on words, and it's not intended to demean in any way this really fantastic initiative. So I do apologize if it sounds like I'm having a joke, but I'm not. It's just very much a play on words. So wounds, really important area and incredibly destroying really in many ways for patients when things get bad enough or almost too late really for anything to be done, associated with stigma, shame, pain, and fear, and proactively identifying people really who are at risk, but certainly who are at the milder end of their wounds, so that we can actually manage these effectively sooner rather than later makes all the difference. Many of us who've done this for a while will recognize some of these issues arising when in conversation with patients. Stigma, very sadly, self-stigma. I've heard this quite a bit here, not wanting to seek help because they believe that these wounds are self-inflicted and they deserve what's happened to them. I think that's appalling, but sadly, that is how some people feel and think. Shame. We've got a number of patients who don't leave the home because they're ashamed of the smell from their wounds. That can sometimes interfere with them seeking treatment, including medication-assisted treatment. Pain, effective treatment for ulcers once they get past a certain point involves quite tight compression, and that's very likely to hurt. And then fear. I mean, again, you know, if things go bad enough, quite often the thing that puts someone off from going in and getting the help is really that fear that this will be them left without a limb. Also, healthcare environments. You may or may not have heard of the term risk environments. And this is something I really strongly believe in as a healthcare provider, is to stop healthcare environments becoming or acting as risk environments that actually increase risk for harms that come to people who use drugs. And unfortunately, many people who use drugs can feel marginalized, judged, medicalized, or criminalized in relation to drug use, and then further stigmatized because of wound odor or the appearance of homelessness. And of course, the big one, struggling to navigate unfamiliar environments and unequal power relations with medical professionals. So where I work now in Forward Leads, we aspire to generate as much excitement, that sounds like an odd way of putting it, but it'll make sense in a bit, as much excitement about wound care as we currently have about micro-elimination of Hep C. But there are some significant challenges in trying to change that perception of wound care and wound aware. So the big ones are around wound care itself and where it should be delivered. So wound aware, I think, is what John Campbell was referring to earlier, which I mentioned a little bit as well as ago, which is more around people who are front-facing, who are helping people who use drugs to have that professional curiosity, to be asking regular questions, to show care and concern about the state of people's skin. And, you know, if you detect a smell, don't just leave it as I've detected a smell. It does require that you ask these questions in a courteous, respectful way, and really to try and catch things at a point where, in fact, you can help heal wounds and not to the point where actually it needs really intense compression, for example. So the severe wounds often requires a degree of management, which involves expertise that actually we are collectively losing. And I mean this particularly with respect to primary care services, tissue viability nurses who hold the kind of primary expertise in actually helping to heal kind of enduring long-standing ulcers, often work alongside district nurses to provide community-based home wound care. And often these would be done through home visits, but they can be challenging as well, particularly in some situations for our patients who might not want those visits happening to their home. And then these standard primary care services are also under increasing pressure in their own right. GP practices often lack space to host specialist clinics, even if specialist clinics were prepared to come out and do satellite clinics. And then asking patients to attend a hospital-based wound care clinic is often a barrier. We have some success locally here in Leeds with our enhanced care team, actually linking people into tissue viability nurses directly without having to go through a medic, for example, and bringing them to appointments. And we are currently negotiating satellite clinics where we have wound care, tissue viability nurses with expertise to come into our 4 hubs and actually offer their services locally in our local treatment rooms. We have access to a mobile consulting or treatment room, which does kind of help people experiencing homelessness, but there are still limitations. The big one being compression bandaging, at least to the extent that our patients need it, is agony for them. People who are on methadone buprenorphine are often not believed when they report pain. And then should they receive opioids to manage the pain, quite often strong opioids, depending on the situation, can increase overdose risk. Buprenorphine can complicate analgesia regimes because of the interaction between them and the way they affect the effect of strong opioids. And then the bandaging process and ongoing management is very time consuming, and it takes a big commitment from patients who often have other survival issues that they need to cope with rather than sitting down quietly and in pain getting the legs bandaged. There's some pilots ongoing at the moment, making use of these mobile care units, fancy way of saying kind of an ambulance that's equipped to see patients, looking at the use of Ethanox during the provision of wound care, wound dressings, compression. I mean, this particular study goes back to as far back as 2003, but some of these activities are kind of being revived again, just taking into account the particular situation that some of our patients end up experiencing. But ultimately, getting wounds under control fast or avoiding their occurrence at all is always going to be preferable. And how do you do this? Potentially making sure that access to sterile injecting equipment is everywhere, preserving expertise, and particularly meaning people with lived experience of injecting. You know, sometimes we do encounter pockets of people who, by what you're looking at when you examine them, you're thinking really that they simply don't know what they're doing, which is unusual. Certainly within my career has been unusual, but now it's becoming more common. Here, deliberate harm reduction, wound awareness, which I've already mentioned, and above all, professional curiosity, that level of caring that really needs to be part of every interaction you have with your patient. Right, so this is the start of that play in words. I hope I don't offend by doing this. So really all I'm meaning is, you know, why are we separating these things? The offer of sterile injecting equipment needs to be alongside medication-assisted treatment and vice versa. I mean, it just makes sense. It's essentially, if you look at if you remember the larger picture I showed you earlier, if this is about health, then you can't really just look at one little bit of health and not look at the rest of it. However, as we all know, somehow this doesn't necessarily happen naturally. And just want to highlight this term that I haven't come up against before, which is intervention stigma. We've often heard, obviously, of stigma that people experience because of the condition they experience or because of their use of drugs or substances or alcohol. Intervention stigma is stigma that they receive because they are in receipt of intervention that we offer them. And that can include, obviously, methadone and buprenorphine, but it seems to multiply if someone walks maybe from one corner of the room to the other after being seen for their opiate replacement therapy to collect injecting equipment. I see that, you know, kind of pretty often, to be honest. And I mean, I feel that the person should be given a gold star for actually making sure they've got sterile injecting equipment, never mind whether they've attended for their medication or not. And I think this is a key issue, I think, somehow that we need to really face up front. I just want to highlight some excellent practice over the pandemic that we have seen in the States in particular. So they call IEP services SSP, syringe service programs. And there's a mix of third sector and I suppose statutory organizations that offer this. There was a change to their policy in the pandemic to enable a lot of mats to be delivered through telemedicine. And that opened up an opportunity for many SSP programs who were continuing to be at the front line, continuing to see patients, to then link people up through telemedicine, through into hubs, and get started on MAT. And you know, during the pandemic, when a lot of kind of MAT services, for example, weren't seeing people face to face, this was a lifesaver, to be fair. And the success of the program relates then to a couple of US clinical trials that are going on. One of them is just as what I've just described, offering medication-assisted treatment through telemedicine platform for people who come to SSP sites. And another one's a bit more extensive, offering also PrEP, Hep C treatment, as well as MAT when patients attend for IEP or for people seeking sterile injecting equipment. So, you know, pretty soon, not only will we have evidence of these pilot programs that were introduced during the pandemic, but also some randomized controlled trials showing the effectiveness of these models just in kind of normal times, such as they are. So WINT, why WAND and not WINT, test and treat. So I just wanted to highlight, if you remember earlier, I mentioned wanting to, or aspiring to creating the same level of excitement around wound care and wound awareness as we do or can do for dry blood spot testing. And I think one of our approaches here in Leeds has been to really inspire our workforce as well as our patients to be proud in a way, or be, I don't know if excited maybe is a bit too strong word, but be proud of being tested and then having the opportunity to have treatment. Treatment is offered at our hubs. Testing, every single person here in every hub knows how to do DBST. And indeed, I circle our local champion, Hep C champion in the hub I'm in right now, who basically has people tested before they even get a chance to sit down. And not obviously in a coercive way, in a nice, friendly way, but nevertheless, we have extremely high levels of BBV testing in our hubs across the board, and it rises year by year. Naloxone, I just want to really say that no longer working in Scotland, the thing that I miss the most is how easy it was to access naloxone just anywhere, everywhere, at any time, through GPs, online, through drug treatment services. It isn't that it's difficult necessarily, but that ease of just being able to say, you know, to deliver naloxone training and be able to hand it out there and then, I mean, that is something to be envied. And I think when you hear from you know, countries like the States and Canada, some areas that really struggle to maintain a supply of naloxone, sometimes because of funding reasons, sometimes because the cost has to come from patients themselves. And here in England, you know, there isn't a national program as such. There isn't one policy really across the board. And so different areas, you know, will rely very heavily on whether or not public health funders decide that this is a priority or not. And, you know, my head and heart is often still in Scotland, and I'm kind of thinking, you know, what about naloxone? And it just takes just a little bit longer to get that going here, whereas it never has been in Scotland. So that's something to be enormously proud of, and I think make full use of that, because it's a life-saving intervention. And this is one area that I have to say you excel. I think that is my presentation.
Great, thanks so much for that, Joe. I know you can't stay for the Q&A at the end, or you may stay for the start of it, potentially have to be away for 2 o'clock. But if there are any other questions as well, we can refer those on to you if we can't answer them today. I'd now like to introduce our final speaker is Donna Thane from NHS Tayside. Donna.
Hi, thank you very much for inviting me to speak. I just start with a wee apology. I'm actually attending the fabulous INSU conference in Glasgow at the moment. So I'm just hoping the background noise here is not transmitting to everybody else, and hopefully I'll just crack on and see how we get on. So I just wanted to give a bit of a perspective about how we are trying to implement MAP4 across Tayside, and some of the challenges. Next slide, thanks. So just, I'm not sure who's in the audience. So Tayside is a reasonably large board area in Scotland. We've got a large geographical area, population of about 415,000, an urban and rural mix. very large urban area, very large rural area, apologies. We have 3 alcohol and drug partnerships: Dundee City, Angus Alcohol and Drug Partnership, and Perth and Kinross. But the majority of our problematic substance use is in Dundee City, where we'll find the largest areas of deprivation, as you might expect. Next slide, thanks. And again. Perfect. So I think I just want to reflect, and I think Joe kind of shared the same data, but just in a different way. This is from the benchmarking report, I think, that came out that the MAT implementation team did a few months ago. So I think the sense was across Scotland that people felt the standard was being met when they were asked. And certainly in Tayside, prior to this, what we have is a specialist harm reduction nursing service and an enhanced IEP service that is run by Hillcrest Futures, one of the third sector organisations. We work very much in partnership, but we had no harm reduction being delivered in our addiction services. I did advise each of our ADP areas that I would have said our position was that we were not meeting the standard. However, I believe they all put in the self-assessment as green. Thankfully, MIST disagreed because, as John also alluded to earlier, they couldn't evidence that that was the case. So it was very patchy. Sorry, if you could click on the next, I think twice, or maybe and another one. I shouldn't have put all these animations in. But yeah, many areas across Scotland interpreted the provision of harm reduction as a referral to an existing service. And that's very much what we had in Tayside. Because we have a specialist harm reduction nursing team, if somebody's referred to them, they're kind of saying, oh, well, we've done it, you know, we've met the standard. And obviously MIST are very clear that that is not the case. If we can, next slide. So what's our approach been? So being a little bit flippant there, there is a bit more of a plan. If you could click on, thanks. So what we agreed at the very beginning when the standards were published was that we should not go down the route of 3 different options for Tayside. It had to be one Tayside-wide option for harm reduction and led by public health. And for my sins, I don't know if I volunteered or was volunteered to lead on that work, but here I am. So we also agreed a phased approach, focusing on our specialist addiction services first and expanding some of the third sector availability that's out there. And we're also beginning to look at hospital settings and custodial settings. And I'm very pleased that HMP Perth in Tayside is one of the pilot sites looking at how they can implement MAT standards in a prison environment. So we're quite lucky that that work will kind of go hand in hand with what's happening there. Next slide, thanks. We've also agreed a way to include some of our lived and living experience work. Just to note as well, though, that this piece of work, so we're doing a survey with some of our people that use our services, but conducted by some of the peers employed by Hillcrest Futures. And I mean, it's much wider than this. There's much more questions and people will receive an incentive to take part, etc. But we did want to focus on some of the things that MIST are also interested in, which is, do people actually want to receive injecting equipment when they see their drug workers, etc. So we've never asked them in Tayside, so we wanted to actually find out if that is the case. We are also, I should just say that this follows on, it's part of a wider piece of work about improving our overall injecting equipment services, particularly in pharmacies, and it leads on from some work that SDF did for us, an evaluation of our services in Tayside prior to the pandemic, which I'm ashamed to say has sat on a shelf, more or less, or in the back of my brain thinking, what do we do with this now? So that is us beginning to pick that work back up again to look at how we improve the quality of the services across the board. And this lived and living experience work hopefully will feed into that strongly. If we can click next. So some of the challenges, I mean, I think all the other speakers have touched on them as well, but we had everyone in a room and, you know, and got into that argument of, well, what is harm reduction? And whose job is it to offer harm reduction? We have some rural and urban challenges that I'll touch on, capacity and competing priorities, a challenge for everyone, and data collection then and performance monitoring. So I'll touch on those. Next slide, thanks. Yeah, so what is harm reduction and whose job is it? So we very quickly agreed that at a basic level, it's everyone's job that are working in the field to go over it. Doesn't matter what your role is, what your profession is, you should be able to, at the very least, undertake a mini assessment of injecting risk. So we have agreed a sort of mini version of the AIR tool that John, I think, discussed, that is on the NEO injecting equipment system, covering some kind of key areas. We have, obviously, we want to be able to provide naloxone, condoms, injecting equipment, foil, any equipment paraphernalia. We also developed a referral for community wound management that our services could use. And I think Joe's talk there kind of touched on that. That's the wound management and wound assessment stuff is the things that has made most of the staff nervous. They really don't feel that, you know, they have the skills, or that, you know, they think that we want them to, you know, be a specialist wound nurse, and that is not what we're asking them to do. So it was just being clear about, we only want them to act within their competence, but to know what to do, who to send that person on to, how to refer them, what else should be done. Even our own specialist harm reduction nurses who will deal with wounds to a certain level, an awful lot of the things that we're seeing is beyond their capabilities to deal with as well. And it, you know, it's admission to hospital, it's, you know, whatever other services required. And of course, bloodborne virus testing as well. We think, you know, that should be offered at every level. Next slide. Some of the more specialist elements is undertaking that kind of full AIR assessment, which our harm reduction staff do, and our in our specialist sites, and our the team at Hillcrest very much are the ones undertaking this with clients, and find it a fabulous tool. And again, like I say, that more in-depth wound assessment by some of our specialist harm reduction staff, and then things like vaccination and stuff as well, that, you know, you can't just introduce anywhere. There has to be a process around that. The one that I've not put on there, a nice little picture, but is also things like STI testing as well, like sexually transmitted infections, and bringing in some of that work too. Next slide, thanks. So in terms of the rural versus urban delivery, we have in our cities, we have mainly fixed sites, and we have agreed with the services that, you know, if you have a fixed site there, you will offer the full range of equipment. You know, it should be everything that's available. But an awful lot of our rural delivery is now outreach, or it is delivered in clinic space that is not owned by our services. So they're going in, they're working, you know, for half a session a week in a GP practice somewhere, or so, you know, they don't have storage space, they don't have cupboards, they don't. So they're basically working out of bags. And so what we have agreed is that there's a nice little picture of the kit bags that we've kind of agreed that people will carry. And I am not above bribery, basically. So I agreed that I would pay, not personally, but I would pay each of this. I've bought these bags for every nurse in every service and every member of staff are in the third sector that work with us as well. So, you know, we've bought hundreds of these bags now so that we can kind of have people carrying equipment. So they'll contain injecting equipment, they'll contain dry blood spot testing kits and naloxone kits, whatever other things people need to take out with them. We have agreed 3 kind of emergency IEP packs that just contain 5 kind of kits with the most frequently requested injecting equipment that we get in Tayside. And those are really a stopgap. You know, the member of staff is encouraged to then advise the client where they can go for more equipment, and also then promote our pins by post service. So this was introduced during COVID as part of our measures to maintain access. It's not hugely been successful. It has been a bit more successful in some of our rural areas, but we're kind of doing another push on that, promoting it so that people can do a one-off order, or they can also set up a kind of a standing order. You know, we want this many bits of equipment, this is what I want, and this is how often I want it, and we'll post that out to you. So we're just kind of testing that just now to see if that is actually going to be something that clients want, and it adds to what we deliver. Next slide, thanks. How will we evidence success? Well, I don't know how many meetings now, most of the people I'm sure here have been about how will we know that the standards are implemented, and the discussions go on forever. But we have, again, I said, like, our approach in Tayside's hopefully to be pragmatic about it, we will use the data that we've got just now, which is we record the amount of injecting equipment that we provide. We do that as part of our responses to Public Health Scotland. So if I know I've got more sites and more equipment going out, then it doesn't tell me about the quality of the service, but at least I know that there is more equipment going out. Again, we can monitor how many air tools are completed. We have fabulous naloxone data in Scotland, and we'll continue to use that as a marker. And we also know the number of tests being undertaken for bloodborne viruses. You know, I regularly get that lab data for the whole of Tayside. So again, I hope to see an increase in that data as well. We will also look at some of the process data that the MIST team wanted, you know, so making sure we do have documented referral pathways, making sure that staff are aware of them and that there's guidance there, and the experiential accounts and regular review. Like, are the services we provide, is it what people are looking for? Is it a quality service? Are people treated with dignity and respect? Those are the things, you know, if we start to hear that that's changing, then we know we're doing a better job than we have been. So looking forward to that. Next slide, thank you. So areas that have achieved, this is actually from one of MIST's documents. So those areas that had achieved or were close to achieving the standard will have documented guidance. So we are kind of, how are we doing in Tayside? We have some things in place, but we haven't yet agreed 3 different standard operating procedures for our addictions teams about how they will embed the practice into what they do. We have equipment at the MAT locations, so tech, yes, our sites are all now set up with Vernacare, and they are beginning to put in their orders to have equipment and to, you know, to have their packs made up and their bags made up. Local champions, we didn't actually go down that route, so we don't have that in Tayside, but what we do have is nominated individual in every service who is responsible for ordering equipment, keeping the NEO system up to date, etc. So in a way, you know, we're kind of our building champions, but it hasn't been called that. Workforce development, yeah, we agreed a training package with, again, using the Hillcrest team, because they're the experts. This is what they do day in, day out. So we use them to support and train each of our addiction services around how to build this into what they're doing. And embedding nurses in the third sector teams. Well, thankfully, we had that anyway in Tayside. Documented referral pathways. Yep, we've now got that. And systems for documentation and data sharing is a work in progress. As I say, there's not really any agreement nationally yet as to what will be recorded for MAT4, but we are part of those discussions at a national level, which is helpful to then be able to influence that as well. Next slide, thank you. Yeah, I suppose it's a marathon, not a sprint. I know sometimes the MAT standard stuff is felt very, very rushed, but you know, lots of changes happening and quickly, and but I do think we are making progress. What we do have as well, or what again, I think from the same document, they suggest that you should have a firm commitment to extend any interventions into justice settings and primary care. But we do have that commitment for justice settings, and as I say, we're working on a pilot. Primary care will need some development work. They're piloting some work in Tayside, just in Dundee actually at the moment, about shared care with general practice. I think it's been quite a hard sell. So that is, you know, it's softly. There's a few practices taking part, and the model is just developing, and they'll look at how they can expand that. So we'll begin to work with them as well about what harm reduction can be on site and how that will be delivered. A harm reduction policy for the whole of NHS Tayside is some quite exciting work that we're taking forward. So we don't have a policy. If people are discharged from hospital, they don't get equipment, there is no, well, they sometimes get naloxone, but there's definitely no consistency around that on our acute sites. So we are pulling together a kind of a proposal to take to the board that they should adopt a harm reduction approach across all areas of the hospital. So I'm really excited if we will be able to take that forward. I hope we will. We are also looking at sustainable vaccine services, not just for this, but for flu, for COVID, for all sorts of vaccines for people who use drugs. And we have some some things we can take advantage of now due to the COVID response. You know, we have full immunisation teams in place now across Tayside that we didn't have before. So there are some things that we can look to build on. Documented referral pathways for sexual health. Yep, it's not consistent at the moment. Some of our services can offer STI testing, some do, some don't. So yeah, I think we just need to kind of tie some of that down. Again, making sure we're getting experiential feedback regularly and acting on it. And we do need to look more at some gendered services work as well. And then the performance monitoring work is just, you know, how do we evidence that we're doing this well, and knowing about it quickly. So thank you.
Thanks so much, Donna. That was really helpful and fitted, I think, neatly with the other presentations, and there was very little in the way of contradictions between them all. Can I ask the other speakers to come back on screen now for the Q&A session? And maybe just to pick up, first of all, on the sort of last point there, around, you know, evidence of success and the RAG status through the MIST team. I guess the first question is, you know, how we define harm reduction, because, you know, if we don't define it, and I guess you're alluding to that, to Donna and Tayside, that what you're trying to do, if we can't define it, then you know, we can't evidence success. And I'm just conscious that Joe is about to leave us, so I'll bung that question to you first, Joe, if I may.
Hi. I don't have a precise answer to what you're asking. However, I do have something that I'm keen to explore someday. I think it's an important point, and that is sometimes it's not just about what's being delivered, although that's really important. It's also what the impact of it is in your community or, you know, city, whatever. So naloxone reduction drug-related deaths, you know, sometimes it's as simple, hopefully as simple as that, but then again, maybe not. But things like injecting equipment, it's not just about how many kits are out there, it's also about the techniques. You know, do they know what they're doing, etc. And if an area, I mean, we're quite good at data collection nowadays. If an area has abnormally high levels of septic arthritis in the spine, in the knees, if you're having episodes of bacterial endocarditis, which prior to injecting substance use really was before the day of antibiotics, you know, if you're getting these spikes in your area, this should be telling us something, you know, if you're getting these pockets. And I just wonder if maybe that is the next step forward, you know, even as we're investing in all these interventions, should we also be asking for data from Public Health England or whoever it is that, or Public Health Scotland, sorry, or whoever it is who has this data, if they could give it to us broken down to specific areas, and maybe with that, link it up to what people's RAG status is in terms of, you know, them meeting the criteria. It's a type of needs assessment, isn't it? If you do this kind of analysis as well, really identifying if we're up to scratch. I mean, John, straight away, you know, you've got that HIV outbreak, which, you know, you guys are doing your best to tackle. Obviously, we would rather that isn't the indicator, you know, because once it's there, then it's clearly very difficult to really get on top of. And of course, people's lives are entirely changed. So yeah, so that's maybe one level of analysis that I would be keen to see going forward.
Yeah, thanks, Joe. Donna, do you want to? You were nodding there. Do you want to come back on that?
Yeah, I mean, I agree. I was thinking that about the, you know, it's infection rates and things. Can we start to look at that community-acquired infections and, as you say, bacterial endocarditis and things? You know, we should have that data. I haven't seen it, but I assume it is there and it's collected and coded. So yeah, I think there is something to be thought of with Public Health Scotland about what other information do we have that would show that we're making impact. So I'll take a wee note for the next MAP 4 evidence meeting to see what we can get.
I guess on the same point of defining harm reduction, do we include things like benzodiazepine prescribing as part of harm reduction, or does that come somewhere else? Laura, do you want to come in on that one?
I think it should all be captured. I think that is a conversation to have. I'm not too sure if every practitioner working in the field would agree with that. So I think that is that wider conversation of consistency. And Donna's presentation said that I think a lot of whose role is what around harm reduction, do you know, that consistency is perhaps what's lacking, and then that has an impact on how we evidence it across Scotland as well.
Yeah,
and I
thanks,
suppose
Laura.
for me as well, that quality, do you know, so how much do we evidence around that relationship, do you know, that conversations, do you know, that's also important when we come to harm reduction.
John, do you want to come in?
That's fine. I'll
Yeah, Dave, harm reduction is a term. It's a term that defines policies, programs, services and actions that seek to reduce the health, the social and the economic harms to individuals, to communities and to society. Now, everyone can agree on that definition of harm reduction, I'm sure. What becomes a little bit more difficult is to measure up against the principles of harm reduction. Harm reduction should be pragmatic. We know drug use has been here for a long time. It's going to be here for a long time to come. It's highly unlikely that any one intervention, such as enforcement or treatment, is somehow going to reduce harms for everyone. Harm reduction services work with the most immediate harms. And even if a person doesn't want to stop using drugs or reduce the drugs or change the combinations, we can still work with them to reduce the harms. Harm reduction services should have humanist values, and those people working in harm reduction service should have humanist values. They should neither condone or condemn somebody's drug use. They work with that drug use as a matter of fact. Harm reduction services shouldn't focus on abstinence alone. Abstinence may be the final goal for the client, and yeah, we can help them take small, meaningful steps towards that. And no one working in the harm reduction field should be working in isolation. We should be looking to maximise the range of opportunities available for individuals. The problem has been over the past 20 years that harm reduction has become a term. It's become a very loose term, where everybody's providing harm reduction, but it's almost nothing concrete. So I'm pretty sure, we would say for Glasgow and Clyde that our alcohol and drug recovery services, very much work with the harm reduction approach. But yet they're based in the communities where people don't have low threshold access to. We talk about same-day prescribing, but you can't have access to same-day wound care or other harm reduction interventions. If that's the case, we've got that wrong. So we're looking at all these big ticket items just now, and we're right to do that. I'm a massive supporter of safer injecting facilities, of heroin-assisted treatment. But this is like putting a nice shiny hot tub in your garden when your garden's a midden. We want to tidy up the garden first before we actually start to have these big purchases. I think we've got a lot of work to do, and I think that's clawing it back. And I do think we've got a responsibility, everyone here in this field, to be a little more clear and focused on what harm reduction actually is.
Thanks, John. If I can bring my colleague Kirsten Horsburgh, who's sat quietly there for the moment, waiting patiently. That's the term. Do you want to bring some? I see there's a number of questions coming in. Have you?
Yeah, I've got a note of some of the things that would be useful to ask. Just wanted to add in a couple of things as well. I really liked your idea, Donna, the providing staff with the kit bags as well. And because for me, it's about that proactive approach to harm reduction. A lot of events that I've been at recently, discussions that we've been having have been around relationships and that relational aspect of care. And it's very disappointing that we need to start talking about actually the real basics are being a nice human to people and treating people well. And we really need to think about how we should be sweating the small stuff, because the small things matter. And harm reduction provision for me is a real relationship builder, and just being able to have that proactive approach in terms of provision is key to your relational aspects in your service. And it reminded me of, for instance, naloxone provision. We talk about what a great naloxone programme we've got, but I remember recently chatting with a drug treatment service about their provision of naloxone and asking, so if you were in somebody's home and they had friends there with them, would you be able to supply them with naloxone there and then? And they were like, they were a service that had been saying that they have really good naloxone provision. They were like, oh no. And I was like, well, why not? Because we don't carry it with us. So just that thinking about that opportunistic approach for harm reduction provision as well is key. Sorry, I'll move on now to actual questions, but I just wanted to get that in. One of the questions that's come up, and you've actually covered it in most of the presentations, but it's an opportunity to talk about a bit wider, is why, when we know that harm reduction is so got such strong evidence base behind it. Why is it not happening in our statutory services? What are the key barriers for why it's not being delivered, and what needs to happen for us to be able to ensure that it is provided in the future going forward? So you have mentioned bits in that, but just an opportunity to expand. Thank you.
Sorry, Laura, but I'll come to you first if that's okay.
No, that's no problem. Certainly for us, I think it's that workforce planning. I think there has, you know, that pressures as well. So I think for me, it's having that consistency that is your basic. So we do it to an extent, but at what stage do we do that? You know, sometimes I think it becomes a tick box exercise, and actually that's the tiny part of that harm reduction advice, you know. So what layers are we putting into that, you know, around, particularly for us, the needle exchange provision is something that we've identified as a gap. Through the MAT standards, we've done questionnaires for the teams, and they already recognise that's not where their competence is and their confidence lies. So we need to be able to support them, so we have that consistent approach that we're not relying on, you can only get that when somebody from third sector is in the building, or you have to go across town to get that. We can give you that. Just what you're saying, Kirsten, opportunistic. Why don't we have that provision within each clinic or GP practice where we can facilitate that there and then?
Thanks, Laura. Donna?
Yeah, I think there's certainly from a Tayside perspective, it was a historical kind of thing. You know, there was this separate team of people who dealt with harm reduction. So everyone else slowly kind of went, oh, that's not my job. You know, somebody else does that. But there was also a sense of, you know, when the MAT standards came in, no, but we do this. The staff in addiction services were saying, oh, but you know, we do this. And the training package we did was very basic. And it was very basic for a reason with them. And a few, not the majority, but a few people that attended complained that the training was too basic. Well, I already know this, I'm a nurse, you know. Well, you might know it, but you're not doing it. Actually, you're not, you know, that's not what our clients are telling us. They're not being offered harm reduction when they go in for their OST. They're definitely not being offered equipment. So although you might know it, it's not translating then to something that's actually happening when the client or the service user, the patient, you know, whatever one, the individual is in front of them. And again, it was that thing that, you know, collecting data is not the be all and end all, but if you can't evidence that it's making a difference, you're doing, you know, you can't just say, oh, well, we know it and we do it. Well, show me how it's happening, because yeah, it's not what we're seeing locally. So
thanks. John?
I don't think we've ever properly invested in a workforce. You know, I certainly don't think there's been any sort of you know, realization that the role of the harm reduction worker now should be one that's very skilled. You know, how can we expect staff and services to, you know, facilitate the discussions on bloodborne viruses and, you know, carry out a dry blood spot sample if we've never trained them to do that, or identify injecting related wounds or complications, you know, and maybe provide emergency first aid in relation to that if we've never trained them. We are now starting to invest in those services that are providing the WAND initiative. So a year and a half ago, we delivered our first advanced harm reduction worker training programme. You know yourself, we have the facilitators from SDF, Sandyford Services, Alison Cool from Lothian, and it's nine advanced sessions that are delivered over a two-week period. That's a level of training that you have to provide your staff. But I think that the biggest barrier is there's been no one leading this. I think we've all just assumed that harm reduction is IEP, it's needle exchange, and as long as we get needles out there, then, you know, that's fine. Well, it's not. The problems are getting worse year on year. Now, if each area was just MAT standards were suggested, if there was no one with any teeth, you know, saying to people, no, look, we need to take these MAT standards seriously and evidence, and then I'm pretty sure the MAT standards wouldn't be happening. So we need to view harm reduction and, you know, with the same regard.
Thanks, John. Kirsten?
Thanks. Yeah, so one of the points that came up, I guess, that's relevant to that as well is about sometimes the punitive nature of prescribing and people not feeling able to be honest with some of the prescribing services. So that potentially affecting their access to, for instance, IEP from a service that, you know, that they're concerned about then their prescription, and maybe perhaps a comment on that. And also if people are leading quite challenging lives, what's been the evidence so far of people engaging in things like the assessment of injecting risk tool, because it's quite a long process to go through that with somebody. And just, yeah, any comments you wanted to make on those 2 points? Thank you.
Donna, do you want to go first?
Yeah, so I think I mean, we definitely see that kind of people not wanting to admit to their addictions worker that they are still using. But we know from some of the work done around our Hep C elimination work that around 70% of the clients that are on OST and Tayside are still coming into our needle exchanges. You know, it's not a small proportion of the clients that are still using the services. So I think attitudes are changing. It does seem that, you know, that way, which is a good thing. I think there is more acceptance that clients, certainly in Perth City, our harm reduction nurses in our enhanced service are co-located with the addiction service, a couple of doors down the corridor. And at first it was a bit of a, oh, you can't be in the same building. You can't have people coming down when they've just come in to see us. They can't come to see you. But now they bring their clients to us. You know, they come and go, oh, I remember going to see Brian and get all your equipment and what. You know, so it just took a little bit of relationship building, I think, with them as well, and for them to understand that this was okay and this is the way we should be working. So yeah, I think sometimes it is about just with staff, it's building those relationships as well and allowing them and making them understand the importance of harm reduction and what we do. And that seems to have made a difference.
Thanks, Laura.
Yeah, your first point, Kirsten, you know, I remember working in treatment services where needle exchange was based, but they had a separate door around the back, so you wouldn't know if your client was coming to needle exchange instead of the appointment. I think there is a historical bit there, and it's how do we get out there and, you know, have up-to-date information about what services available now and what stigma's not around that. So, you know, there's not going to be punitive measures if you're still injecting whilst in treatment. It's not months to get on a prescription. I think it is being proactive around that. It's certainly something I did around MAT1 was going out with third sector to people's doorstep, get on the needle exchange delivery and having that informal conversations of how was your experience coming into treatment, what's putting you off, and that thinking pattern is still there, that it's really challenging to come in, that it's still, you know, three samples with substances in and you're kicked off a script, you know, that's still there. And for me, that's really upsetting, that why are we not getting the right information out there to say that it's not like that at all. So I think it is around education and being proactive of how we put that out where people are actually going to reach it in a way that they can access it.
Yeah, that's a very important point, Laura, and certainly some of the work that we've done shows that, you know, people seeking services often don't know of the existence of the MAT standards, you know, let alone other things. So we've got a long way to go, I think, in terms of communicating that. John, do you want to come in?
Certainly before I introduced one that was difficult, you know, to get clients through the door and spend a bit of time, and you know, at that time there was no real assessment injecting risk, but difficult getting through the door and even provide things like a dry blood spot sample. So the incentive for us, you know, was an absolute game changer. Yeah, people probably don't want to sit for half an hour and go through these interventions, but if they get £20 at the end of it, you know, then it maybe changes their view. But certainly what we've identified is the clients are getting through that. We're seeing a reduction in harm, and I would hope the clients are seeing benefit then in taking part in their needs, because it's never happened before. We never really sat in any meaningful way and spoke to people about how they prepare and inject the drugs and the tactile part, the tactile nature of the assessment as well. So it is new. It's new for everyone. I think the problems could come with how you incentivize those interventions from services. In fact, it's a discussion of whether they should even be incentivized from services or not.
Thanks, John. I think we've time for maybe one or perhaps two questions, depending on.
Yeah, so I'll give you a really quick practical question, then we'll finish with maybe a wider one. So the quick practical one is, why is it that we're still using dry blood spot testing and not so much the rapid tests that are available as well?
John, do you want to?
Yeah, the dry blood spot tests, and we test for hepatitis B, hepatitis C, and HIV. We do use a rapid test in some of our services, but that has to be backed up by a dry blood spot test as well.
Thanks. So I guess the last one then to end on just would be, in an ideal situation, what would MAT4 look like?
Okay, Donna, do you want to go first?
I think it is, as we're described today, and as Joe kind of said, it's hand in hand. Wherever there is OST, there is MAT, and they're not disaggregated ever. And it just, that kind of stigma and things just is not there around it. There is no kind of, it's just second nature now, that when you go in to discuss it, you're also discussing all of these other items about your risk and how can we help you to reduce that. And I think that's it. And we will only really know that when we get a lot of that experiential data telling us that that's happening consistently across Scotland.
Thanks, Donna. Laura?
I don't think Joe's very good point around why are we just looking at one part of health and not everything. There's so much there to learn. I think that's something really valuable to look into further. For me, it should be consistency across everyone that's working with people, accessing any form of services regarding their addictions. And what's on the table for them is meaningful, but also evidence-based. So I think putting workforce planning in, let's invest, like what John said. I think that is something, who do we lead with this, to have some consistency across Scotland, so it's not postcode lottery over the health boards.
Thanks, Laura. John, we'll give the last word to you.
Yeah, okay. Well, I think MAT standard 4, obviously, MAT standards in general, very welcome. But MAT standard 4, yeah, of course, people receiving medication-assisted treatment should have access to a range of harm reduction interventions. What about those individuals engaging with services that aren't receiving any sort of ORT? Should they have access to basic harm reduction interventions? In fact, what about the communities where our drug services are housed? Should people in the communities have the low threshold access to these interventions? Because we are absolutely missing a trick. If the trajectory of the increase in cocaine injecting and the reduction in heroin injecting continues, then we're going to have a lot of injecting-related complications within the community. And the reality is we're going to have very little to offer that population in relation to medication-assisted treatment. So we're future-proofing it and trying now to expand this and start to make inroads into the community and plant the seeds for the future.
Yeah, that's a really important point to end on, John. Just to say that there have been quite a lot of other questions that we haven't got to, but we'll attempt to go through those and go back to the speakers today to get those answered to you. Sadly, we've come to the end of the webinar. But this has been recorded and an edited version will be published on the SDF YouTube channel as soon as possible. The MAT Standard 3 webinar from last week will be published this Monday. We'll be sending out an evaluation shortly and be helpful if you could complete that. As highlighted, this is the 4th in the series of webinars on MAT Standards implementation. The session on MAT Standard 5 will run at the same time next week. And if you haven't booked for that session and would like to do so, a link will be provided in the evaluation email. We're also now putting out details of the webinars for MAT Standards 6 to 10. So if you look out for those and booking for those as well, that would be great. So finally, I'd just like to thank all of you for attending, and a special thanks to today's presenters. I think you'll agree it's been a very stimulating discussion that we've had and highlighted a lot of work that still is to be done in terms of delivering harm reduction, not only within MAT Standard 4, but across the board. Thanks again, and goodbye for now. Thank you.